Good afternoon. Postpartum depression is not only a problem for mothers, it's also a problem for our children. It is important to recognize it. It can affect our kids emotionally, socially, and physically. What better way to screen for postpartum depression than at well-child visits? My project will focus on improving screening rates for postpartum depression at well-child visits. So just a little history on postpartum depression. It is a mood disorder that commonly occurs after a woman gives birth. It's different from postpartum blues, meaning that it lasts at least 2 weeks, can last up to a year. It affects 1 in 7 women. It can interfere with the mom and baby interaction. And most importantly, it can be treated with medications and counseling. So it's very important to recognize this for our children's well-being. Postpartum depression screening that we use at our clinic is part of the Implicit model. And the Implicit model is a framework that we use from the maternal child AHEC that focuses on interventions and quality improvement measures to decrease preterm and low birth weight outcomes, low birth weight infants. And again, well-child visits is the perfect time to screen because normally after a mom delivers, she sees either her family physician or her OBGYN, and usually that's 4 to 6 weeks postpartum. If postpartum depression is identified early, meaning before mom is discharged, she could get a 1-week mood check, but that's about it as far as her visits. So if we screen at well-child visits, then we have more opportunities to identify postpartum depression concerns because the children are seen at their 1-week visit, 1 month, 2 month, 4 months, 6 months, and so on. And again, postpartum depression can occur up to 1 year. So the purpose of my project was to assess our current workflow and work on improving our workflow. And that is using the 2-item patient health questionnaire, which is also known as the PHQ-2. And if that's positive, you would then use the 9-item patient health questionnaire, which is also known as the PHQ-9. And this is to be done at each well-child visit up to 1 year of age. And our setting was in Wilmington, North Carolina, at our family medicine residency clinic. And looking at studies show that the PHQ-2 is just effective alone as far as identifying postpartum depression concerns. It has a sensitivity of 100% and a specificity of 79.3%. If the PHQ-2 is positive, then you would instruct mom to do the PHQ-9. So I wanted to look at the problem first. So currently in our clinic, the number of postpartum moms with depression is unknown. We didn't have a standardized workflow in our clinic. And also the number of mothers on antidepressants and in counseling was unknown. So I wanted to look into this further and identify how many that we had. Okay, so discussing my goals, objectives, and measures. So I wanted to look at the number of positive screens and look at the interventions. And one of my goals was to screen all mothers with infants less than 1 year of age at each well-child visit, only if mom was present. I wanted to increase our screening rates by 50% over a 3-month period. And then I also wanted to increase our documentation rates for the PHQ-9 scores for every positive PHQ-2. So the way I got started, I did a literature review at the beginning of the year to look at postpartum depression screening methods. And so the literature that I reviewed was looking at the PHQ-2 and PHQ-9 together versus using the PHQ-9 alone versus using the Edinburgh. And studies show that either 3 could be used, either of the 3. And I also use a PDSA framework, which is the Plan, Do, Study, Act for my project. And then I reviewed our baseline data for our postpartum depression screening rates. And this was reviewed over a 6-month period from January to June of this year. And then looking at our baseline data, we saw that the PHQ-2 questionnaire was only included in some of our Bright Futures questionnaires that the mothers complete. Then I held a training session in April, and that consisted of faculty, residents, and our staff just providing training on postpartum depression screening, why do we do what we do, the importance of it, how to bill for it, how to document, and how to record our interventions. Then I created a workflow algorithm for positive screens with a referral workflow. Then I did my new screening intervention on June 25th, and that was, I took a form with the PHQ-2 on the front, and if it was positive, the PHQ-9 was on the back for the mother to complete, and this was stapled to each Bright Futures questionnaire that the mothers completed at the well child visits. And then we looked at monthly reports to look at our data rates. And then after the intervention was in place for 3 months, we compared the data with the baseline. And this is just a picture to show my PDSA model that I'll continue to talk about. And this is the workflow algorithm that I use. So basically, when the mom check in with the child, the front desk staff would provide the packet for the moms to complete out. So the moms would either complete the forms in the waiting room or while they was being roomed. The MA, our nurse, would record the scores in our Epic electronic health record, and then the provider would review the scores with the patient, with the mother. And here's a picture of my sample PHQ-2 that I used. And this was stapled to all of our Bright Futures questionnaires. So this is basically asking the mom how she's felt in the past 2 weeks. And if the score was 3 or greater, she completed the backside. This is our maternal screen that we have in Epic, and this is how we record our data. We have a data analyst person that looks at our data, and she manually record our scores, just so we wouldn't have duplicates. This is my referral algorithm that I use because we had some mothers that wasn't a patient to our practice, so I thought that was important. So if they were a patient to our practice, we would refer them to our behavioral health counselor if the score was positive for counseling. And then also they would have an appointment with their primary care provider for medication. And then if mom was not a patient at our practice, then we would refer them back to their PCP so they could get counseling and medication. And then if mom didn't have a PCP, we gave her resources in finding one. And then we also had an algorithm if they had immediate concerns, like if mom was suicidal. So on the left-hand side is the results showing the baseline data. So the orange bar is the number of well child visits completed with mom present. And then the red bar is the number of PHQ-2s completed. So there were about 26 missing PHQ-2s that were not completed. And then the green bar shows the number of positive PHQ-2. The green bar represents the number of positive PHQ-9. So there is a discrepancy there because only half were completed. And then we had one mom that tested positive for postpartum depression. And then on the right side is the post-intervention for 3 months that was started June 25th all the way up to October 5th. So the orange bars show the number of well child visits with mom present. Again, you see we have discrepancies in the number of PHQ-2 completed. There was about 25 missing. But with our number of positive PHQ-2, we had a PHQ-9 completed for each one, which was 10. And then out of our PHQ-9, we had 6 mothers who screened positive for postpartum depression, and that was in 3 months. So this is just reviewing our demographics with our postpartum moms. So most of the moms have a high school educational level. Most of our moms have Medicaid insurance. And then the majority is either Caucasian or African American, and between the ages of 20 to 29. And then with our 6 moms who screened positive for postpartum depression, all but one was a patient at our practice. They were between the ages of 22 and 32. The positive screens were noted at 1, 2-month, 4-month, and 9-month well-child visit, with the average being at 2 months postpartum when postpartum depression was diagnosed. The average race was Caucasian. Half of the patients were on antidepressants, and only 17% were in counseling. And all of the moms had at least 2 kids. So looking at this quality improvement project, it showed that more moms were identified with postpartum depression concerns, and therefore more interventions were implemented and more moms were treated. One thing that I did notice is that our staff compliance rate didn't really increase, so that would be a future goal to work on, is making sure that the education continues so that we won't have any missing PHQ-2 screens. Another goal that I would like to work on at this point, now that we have more moms screening positive, is starting postpartum group visits, home visits, and maybe a hospital support group. And these are my references, and thank you for your time.